mostly, but just some interesting things too that might be new for you. So, of course, everybody knows what gastroenterology is, unless you don't know, but oftentimes people don't realize that it also includes your pancreas and your liver, and not just the tube that goes through you. So we see people with cirrhosis and with pancreatitis, things like that, other than just stomach problems and problems with colon and cancers and things like that. But a lot of times there is some confusion. People think that we do surgeries, but we don't generally do surgeries. Most gastroenterologists don't do surgeries. Sometimes we'll do procedures, so endoscopic procedures, meaning through the tubes, but we don't actually cut you open and do that part. There are some specialist gastroenterologists that will do that sometimes, but most of the time, so if you need surgery, like your appendix or something, we don't do that part, for the most part. And we don't do anything above the esophagus either. So, if people have something in the back of their throat, we send that to ENT doctors. So I just wanted to make it brief and just a few important things I encounter frequently and that I wish more people would know about. So, but that would probably mean I'd see fewer patients, and that might not be good, right? So maybe I shouldn't tell you all this. Leave you in the dark. So, let's go on. So I see a lot of people with constipation, a lot of people. And it surprises me how many people don't take any action to deal with it before coming to see us, and they could save themselves a lot of trouble by just taking a few simple measures to keep that from happening. So there's a lot of reasons why people have constipation. A lot of times as we get older, the nerves and the muscles just slow down a little bit. You need to have, and as it slows down, it can get harder. And sometimes your feeling isn't there that you need to actually go. So that's why they recommend that you have plenty of fiber in your diet. If you don't get a lot of dietary fiber like greens and whole grains, oatmeal, things like that, then sometimes you can take a dietary fiber supplement. There's lots of different options. A big question I get a lot of the time is Miralax fiber? People a lot of times think Miralax is fiber. Miralax is actually a laxative, but we use Miralax probably more. It surprises me. Probably, 1 out of 5 patients I see, I'm recommending Miralax for them. It's that because it's so safe to take Miralax long term. It's basically just kind of like, think about how electrolytes. Have you ever heard of osmosis? Back when okay. So we call that an osmotic laxative. So what that does is, think of like an electrolyte that doesn't get absorbed into your body. So water collects around that, and that retains the water inside the colon or the bowel, and that makes everything a little bit softer and easier to pass. Go ahead.
Is Miralax over the counter?
It is. And there's, I'm using Miralax, but it's polyethylene glycol. And there's a lot of generic versions. I think there's one, Clearlax is HEB or something like that. I don't know. They have generic versions and all that. So, and there's tons of different fibers too. A lot of times people will just try one fiber, they'll get gas, and they'll say, well, I'm not going to take a fiber supplement. Well, it could just be the kind of bacteria that you've got in you that can digest that. And so switch to a different fiber. People do it all the time. Metamucil is psyllium fiber. Citracel is methylcellulose. I basically tell people it's just like eating paper. But that one won't produce much gas. And if you really hate the flavor of things, Benefiber, they make some products that dissolve in water really well. You can hardly tell it's there. So Usually if people are getting plenty of fiber and sometimes having to add a little bit of Miralax, we don't have to do anything. We've got lots of good medications for constipation now, but most of the time we don't have to go that far. Go ahead.
How about taking probiotics?
Oh, I'm gonna talk about that in a minute.
Oh, okay.
So, other things you can do for constipation, just remaining active, moving around, just that shaking motion and everything, making sure you get plenty of water. A lot of times as we get older, we also don't have a sense of thirst as much. So just being more cognizant of that and making sure you get plenty of water. So the medications we've got, they're kind of cool too, but they work like basically the same way as the Miralax. They just reverse, instead of you absorbing salt, they either keep the salt in there or they push salt into your gut. So that brings the water, so it's the same thing. Softens that up by putting salt in there. And they're pretty cool, but they're kind of expensive. It's a lot cheaper to use Miralax. And then, for special situations, like if you take pain medication long term, a lot of people do that. They can get constipated because that slows everything down sometimes. It's, the same reason it's slowing down the pain. There are medications that can counteract that as well and kind of neutralize that effect in the gut so people can go better.
I find, excuse me.
Go ahead.
So I've been still eating the same things I do, but I find that eating a fruit before I go to sleep, like in the afternoon before I go to sleep, it works. It works.
Yeah. Okay. Another thing I wish people knew more about, and I'm surprised they don't, is if you take a lot of aspirin or ibuprofen or Aleve or anything like that, if you take it for weeks and weeks because maybe your knee's hurting or whatever, you can have this catastrophe of starting to have a bleeding in your stomach or your small intestine because of the medication's effects. So the unfortunate thing about those kinds of medications is that they can inhibit some hormonal sort of signals that allow you to protect your stomach. So you've got kind of a balance between your acid in your stomach and your protection in your stomach. If one of those gets out of balance, say your protection goes down and your acid doesn't go down, you can have that burn the lining of your stomach and give you an ulcer, and then you can start to have some bleeding. So it's surprising how many people come in, they've become anemic because over time they've had just steady blood loss from taking these medications too much or for too long. So sometimes it's just a kind of like taking a risk. Your doctor is prescribing you something in this family. They're giving it to you because they want you to have a good quality of life. But you just got to be aware, if you start having pain or something, that's the first thing to stop, is to eliminate those kind of medications. There's lots of prescription medications in this family too. Another thing that people don't realize is that it's one of the major reasons why people have a medication-associated diarrhea. So, they'll think of foods or infections and other things, but they won't think about this medication that they take every day. Anybody have any questions about that?
So, NSAIDs, that refers to
Non-steroidal anti-inflammatory. So steroids reduce inflammation, and they call this class of medication non-steroidal anti-inflammatories.
Tylenol, what is it?
Tylenol is not. It works in a different way.
but Aleve and aspirin and.
Aleve, aspirin,
and-
yes.
Okay.
Okay. And this is, if our doctors have to go to the hospital, besides, there's several different things, but bleeding is probably top 3. Somebody's bleeding, we don't know where it's coming from. So if people, it's one of those things about modern life. Got a lot of things over the counter that can hurt you. So next one, everybody's had a colonoscopy, but tell all your friends too. So colon cancer and basically just GI cancers. If you add up all the GI cancers, including liver and pancreas, is 50% of cancers. So it's number one if you think, in our practice, that the cancers that gastroenterologists diagnose or find or are usually involved in, it's 50%. So, but there's kind of a mismatch. Over time we've been getting better at detecting these things. So that's just first, second, third, like that. So you can see the death rates from colon and pancreas cancer are fourth and fifth, but cases, if you notice, there's a big difference, big jump between colon cancer and pancreatic cancer. That's because pancreatic cancer is very deadly. It's usually found.
Why is that so?
It's found later, and it's asymptomatic for a really long time in a lot of people. And so by the time it's found, it's also very aggressive, and it metastasizes easily. So
I was reading where colon cancer is now found in younger people.
yes, so I didn't put that on there, but we are now screening people at 45 rather than 50.
One of my daughters and son-in-law's friend, 38, she just passed away this summer.
Yeah.
38.
Yeah.
Colon cancer.
The guy that played Black Panther? That
Oh,
guy?
yes.
He had cancer, he had colon cancer while they were shooting. And then afterwards he had some bleeding, I think, and they found it, and it was pretty advanced. So yes, it is happening younger. I don't know all the different reasons for that. Could have something to do with dietary changes and things like that too. But people are getting screened, and the death rate and new cancer rate's been steadily going down over the years. So, making progress there. Same thing with deaths. Getting caught earlier, and that's because of this next thing. This is, over here on this side is, basically at what stage does a cancer get found? And then this is the survival rate after the number of years, so 1 year, 2 year, like that. So if it's caught really early, that's this red line here, okay? You're talking about, 75% of people after 74% will survive that. That's where the colon cancer is still limited to the lining of the colon, and it really hasn't spread anywhere else. It's not in the lymph nodes, or they go in, they cut it out, and they say the entire thing was cut out all the way to the bottom. There were no cancer cells, attached deeper. And then the other levels are, how much it's advanced. So, if it's too far along, that's really bad news. So this is why we want to screen people. If we can catch it early, then you've got a very good survival rate.
How would you find it early?
Just regular screening, or being really, if you've got some blood or something, taking that seriously. Also, certain people, when they get screened, they find out they're more prone to have polyps. And in that case, those people are getting screened more frequently, and that can be very helpful to prevent cancer on their part. And then another thing is I see a lot of people with a certain kind of bacterial infection called Clostridium difficile. Have you ever heard of that before? No? Mm-hmm. So this is it's kind of epidemic. When I first started practicing back when, probably about almost 20 years ago, I just didn't see very much of this. But now it's just like, it's all over the place. And so it's
Say the name again.
Yes.
Clostridium difficile, or C. diff. A lot of people call it that. Yeah. So a lot of people get this after going to the hospital, or they're in a nursing home, or where they're around people that have it. But what we think is happening too is that there's a lot of antibiotic use, and when you take antibiotics, sometimes after that, you'll be colonized with this, or maybe it was even present prior to, and then that bacteria is particularly resistant to antibiotics. So then it doesn't have any competition after you've cleared it. Say you've got a sinusitis or something, and you get some antibiotics, and then you get diarrhea. Sometimes it's because you took the antibiotics, your gut bacteria all your friendly bacteria are knocked down, and then the C. diff can kind of dominate, and then it produces a toxin which can make you pretty sick and even lead to hospitalization. It even has killed some people. So that's one of the things that I try to tell people all the time is that alcohol and everything is fine for viruses oftentimes, or a lot of other kinds of bacteria, but this particular bacteria produces a spore. So it kind of goes into hibernation mode, where it's resistant to cleaners and resistant to drying out, and but once it gets into your gut, it will pop out of its little protective shell and start causing problems for you. So that's why you should, if you've got an opportunity to wash your hands, you should do that preferentially over using alcohol wipes, or rather gel or something like that, because the only way to get rid of the spores is to physically remove them. So if any questions about that? Okay. This is also a reason why, and I used to be in family medicine, and I would do my best to talk to patients about the appropriate use of antibiotics. It's not at the first sign of sniffles, we don't need to use antibiotics. And this is one of the things that can happen when there's overuse of antibiotics. More people can be exposed to this vulnerability, of getting this.
And more people, like at school, there's Germ-X everywhere,
Right.
Before, everybody was washing their hands, and now it's this sanitizers that are all over.
Right. It's better than nothing.
Oh, better than nothing.
But not good enough for the C. diff. Okay. The bane of my existence is talking to people about bloating. It is one of the most difficult things. Sometimes it's the only thing that's bothering people. If I had $1 for every time somebody said that they felt like they were pregnant again or something. So there's a lot of reasons why people can feel bloated. Sometimes it's just a nerve issue, but a lot of times it's dietary. And so as we get older, we produce less of the enzyme that is necessary to digest lactose. This is very common in anybody but European people. This happens really early, but European people have a mutation that lets them produce the enzyme longer into their life, but eventually it's going to catch up with you. And so a lot of times, I'll see somebody in, I'll just have them eliminate everything that's milk. Now cheese and butter are okay, but no ice cream, no milk, no creamer, and oftentimes that'll be all they need to eliminate their gas. Another thing a lot of people don't think about is certain artificial sweeteners. The same thing. They have so many different kinds now. Some of them are like chemicals that make you taste sweet in your mouth. Other ones are actually sugars that have been modified so that you can't digest them. Well, you can't digest them, but bacteria can digest them. And so you end up having a lot more gas. So, sometimes two people come in and I'll say, are you using, oh yeah, I'm using lots of Crystal Light. That's Crystal Light. It's terrible. Just get them to stop Crystal Light and they're good. And then there's other foods. So I'll let you research this on your own, but these are this acronym FODMAP. That's basically, I won't go through it, but the F stands for fermentable. Okay, So there are certain sugars and things in foods that are present that have the same effect. We can't digest them real well, but the bacteria can. So, you know, the list is too long for me to go over right now, but they're not bad foods. But, you know, sometimes watermelon will get people in trouble, or certain other kinds of foods. They're often got some fiber in them and things like that. So,
Grapes and stuff like that?
well, it's just a list. It's more like a spectrum, and it's also has to do with how much you have.
Yes.
You know, if you eat a whole watermelon, expect problems. but you know, if you just have one slice, it's probably not going to cause a problem.
So if you go research it, you go FODMAP?
Yes.
foods?
Yes.
It reminds me of Cameron. It's like Cameron right here. You just remind me the way you speak, the way you talk, and your mannerism.
Well, you must be a very smart guy.
He is. Yes.
So, probiotics. This is like, so I listen to a GI podcast to try to keep up to date on things that are happening in the GI world and if there's any new developments, because I don't want to be caught flat-footed by a patient. That's always the worst thing to happen. So, it's always it's like a running joke with this guy on the podcast that it's the holy grail of GI medicine to find some you know, special wonderful bacteria that's going to solve all of our problems. But this has not really happened so far. They are doing they do studies all the time to see if it has some sort of impact on any particular condition, and it's always just a wash. Now, I tell patients all the time, if they make you feel better, if they regulate your bowels a little bit better, then go for it. It's not going to hurt you. But I can't really endorse anything in particular except these two for any condition. So this company, VSL, is a particular blend or bacteria. It is super potent. It's like a huge amount of bacteria compared to what you'd get over the counter most of the time. And they did find that helps people with certain things like IBS. I don't know if you've ever heard that, like irritable bowel. Some people get a benefit from that. And then there's another bacteria, and this is available over the counter too. This has to do with the C. diff. There is some benefit to taking this particular bacteria probiotic after you finish antibiotics to prevent C. diff from coming up. It's kind of a weak impact, but it's better than nothing. Any questions about that?
My stomach was always making noises, always.
Mm-hmm.
And now I take probiotics. I started in summer when I visited my daughter. And so it's not as noisy or hardly any. It's helpful.
Well, good. So I get questions a lot about herbals too. So there are a couple things I tell people all the time. So if you take a magnesium supplement, sometimes that can be a substitute for Miralax because magnesium doesn't get absorbed in this thing very well. So it's the same idea as the Miralax. It just kind of keeps water in there. Ginger actually does a pretty good job. A lot of pregnant ladies know about that. It works pretty well for nausea. And then I tell people to get peppermint oil capsules all the time to help with, you know, kind of just indigestion or abdominal discomfort. And very safe and very mild, except, you know, peppermint and ginger you might have, if you've got reflux problems, might be not such a good idea. Okay. So now we transition into more, I heard you guys like cutting edge or interesting things. So we can talk about a few things that have been developed in the past few years that I think are kind of cool and interesting. So let's play this short little video. So this is for people who have issues with reflux.
The lower esophageal sphincter, or LES, is a one-way valve that separates the esophagus from the stomach.
Good way to increase the volume.
The LES opens transiently to allow passage into the stomach. flowing back up into the esophagus. However, for patients who suffer from reflux, the LES abnormally remains open, allowing stomach secretions and contents to reflux up into the esophagus, causing symptoms. Should conservative management with medications as well as diet and lifestyle changes not resolve reflux symptoms, such patients may be a candidate for surgical intervention, which typically involves physically tightening the LES. Traditionally, a Nissen fundoplication or stomach wrap is the standard approach to surgically tighten the LES and requires small incisions over the abdomen. However, there is a procedure that can tighten the lower esophageal sphincter without any incisions called transoral incisionless fundoplication or TIF. There are several ways of performing TIF. The method shown here is via a device called Esophax made by Endogastric Solutions. Under sedation, the esophax device is introduced into the mouth under endoscopic guidance and threaded down into the stomach. The endoscope is then angled so complete visualization of the LES site is maintained at all times. The device jaws are then folded into its active state. The stomach wall is then retracted into the jaws of the device. If a small hyperhernia is present, suction provided by the endoscope can be used to reposition the hernia below the diaphragm before device activation. Once the stomach wall is positioned correctly, the device can be activated like a stapler, resulting in fasteners being deployed to hold the stomach wall in place and secure the fold. The stapling is then repeated in multiple specific locations to recreate a natural functional sphincter. With healing, scar tissue develops which further secures the newly formed valve.
Okay, any questions about that? I don't know if they play piano music while they're doing it during the procedure. It would be nice though, but you'd be asleep and you wouldn't be able to tell. But that's something we've not had to send anybody for that yet, but there are some doctors down in Houston that do that. And so it kind of makes a one-way valve so you don't have as much reflux. Okay. Another thing, there's a condition called gastroparesis that can happen to people who have diabetes. The paresis, think of paralysis. So the stomach doesn't work properly. It makes people feel really sick, have nausea, vomiting. They can lose weight because they're having such difficulties. That now they've got a gastric pacemaker. So if the nerves don't work properly, then we just stimulate the muscles to contract, and that can really help people's symptoms. And they just kind of turn it on with a little device, and after they have a meal. And I haven't had anybody have to use that yet either. Usually when I tell people about it, they're like, oh no. Even if they have really bad gastroparesis, they're just not interested in having that in their belly. But any questions about that? So links. This is another thing that's been used. I do have some patients that have used this. That is. We'll go back to that in a minute. But basically, using the same idea to keep the reflux from coming back up, they'll now surgically go in to the lower esophagus and place it looks like a little beaded bracelet around the lower esophagus, and those are those really strong, I don't know if it's neodymium or whatever, the super strong little magnets that you have. It's kind of like that, and it will just clamp down gently around the lower esophagus and give you a little bit more of a seal. But because they're just little beads, they can separate when food comes down. So I do have one lady that's had that, and it's working really well for her. Only disadvantage to that one is that, obviously you've got this magnet in there, so if you get an MRI, they just go, ugh. that magnetic field completely destroys them. They don't pull out of your body, they just stop being magnetic, which is kind of weird. So people just unfortunately can't get an MRI in that area. Okay. I guess they thought it was too gross. Let me see. Okay, here's another cool thing. So, an impact that is probably going to make a big difference over the next 10, 20 years is using AI to assist us. And one of the ways that can happen is in the identification of things that maybe the practitioner isn't seeing, can potentially miss, but the machine has 100% attention, of course, all the time. So one of the things that they're trying to work on, and this big mad rush to see who can deploy this the fastest, because it'll probably, if one works really well, they'll probably take over the market, is an AI-assisted colonoscopy, where it would basically mean that you would miss, or your doctor would miss fewer polyps, because that is something that happens. They try to keep that low. They compare themselves to other GI doctors to see if they're performing well, but this could kind of up the game a little bit on finding those. So they train a computer system to be able to identify pictures of polyps, basically. So as they're going through, on the edges here, it flashes red when the computer sees a polyp. So it can give them a little bit of a clue. Oh, okay, there's a 59% chance that there's a polyp there, 42% chance, and there's. So these are very small. This looks big, but these are really, really small little guys. I think that's 3 millimeters is what they said. So anyway, if you wanted to ever know what a colonoscopy looks like, it looks like this. Hours and hours of this, by the way. So.
Is that the polyp right there?
Yes. That's a good opportunity to see what it's like. So they'll take, when they see that, they'll take, through the same device, they'll send a little, looks like a little, you know those little alligator claw things you can use to clip on stuff? Looks like that. It just goes out and you just go, whoop, and grab it. Sometimes they can also do a little, they can kind of use like a snare. Looks like a little lasso, and they'll grab it and then try to suck it into the pathology container.
So what causes the polyps?
So as we go through life, the inside lining of your colon is subjected to a lot of damage. You could say it's having to deal with a lot. So most of the time you'll see more polyps and more cancers over here on the left side, because that's where things tend to sit for a while, right, and be exposed to the surface. But over time, your cells, the way I explain it with colon cancer is your cells have a self-destruct mechanism built into them that if they sustain too much genetic damage, then either the immune system will take them out because they look weird, or they will self-destruct. Sometimes the self-destruct sequence itself is broken. And then if the immune system doesn't catch it, you can have accumulation of more and more damage over time. So they've mapped this out, like one of the most detailed paths to cancer is with colon cancer, this kind of stepwise damage. And you've got so many cells, it's just like a numbers game. So You know, things like smoking and other things are going to increase damage, okay? Some people are just gonna be more susceptible because they already have some pre-existing, just because of their you know, they inherited it, that they've got some predispositions to cancer. And so you see this just kind of damage accumulating, and then finally it turns into uncontrolled growth. Does that make sense?
Mhm.
And this one is kind of cool. This is also about cancer. There's some new technology now that allows us to be able to tell, you know, whether cancer is still kind of present in your body, even if we can't see it on any kind of scan or by blood test or anything like that. And it's going to be very, they're trying to expand this into many different kinds of cancers. There's this particular company, but I'll just play the video and you can see for yourself.
After surgery or chemotherapy, how do we know if there is any cancer left in the body? Currently, clinicians rely on imaging and blood tests to look for signs of remaining cancer or recurrence of cancer. The DNA that cancer cells release into the blood is called circulating tumor DNA, or ctDNA, and is typically present at very low levels. But are imaging and conventional blood tests sensitive enough to detect molecular traces of cancer in the body? Signatera is a new blood test that can identify molecular residual disease or recurrent cancer sooner than existing methods by detecting the presence of ctDNA. Signatera is a personalized tumor-informed test optimized to detect ctDNA with high sensitivity and specificity. First, whole exome DNA sequencing between the tumor tissue and normal cells are compared to identify mutations unique to the patient's tumor. Next, for each patient, a Signatera test is created to track the top clonal mutations, similar to a unique tumor signature. This personalized tumor-informed test can then be used to detect, measure, and track extremely low concentrations of ctDNA in the blood during treatment and remission. Physicians can use Signatera to support more informed treatment decisions by determining risk of recurrence, detecting early recurrence, and assessing changes in ctDNA levels in response to therapy. A positive Signatera result means that ctDNA is detected in the blood, and there's a higher risk of cancer returning without further treatment. A negative Signatera result means that ctDNA was not detected in the blood, and data shows the risk of cancer recurrence is greatly reduced. Serial negative Signatera results further confirm decreased risk of recurrence. Revolutionizing cancer care begins with revolutionary testing. Learn more at nateraoncology.com.
So can they detect it prior to you ever being diagnosed with cancer?
No, because it is looking at the specific, as far as I know, there may be something I don't know. It's possible, I suppose, that they could look for more common things. But what I think is most interesting about this technology is that they are making a test that only is appropriate for you, for your particular cancer. So it can even distinguish between something new, like if you had something in another organ, you're like, what's that in the lung? Okay, well your Signatera test for your colon cancer is still low, so it's not the colon tumor. So very interesting how that works. But this will hopefully, this technology will mean that some people will be able to avoid some of the more negative effects of treatment if they can, get negative tests over time.
So are the colon cancers all individually different? Or are there?
This is just talking about your particular cancer. It's going to be the damage that was sustained that led to that cancer is going to make certain genetic changes. And so they figure out, okay, your normal cell has this genetic profile, your particular cancer has this genetic profile, so that they can distinguish between the cancer and you.
In terms of colon cancer, how many types of colon cancer are there?
Well, I mean, we usually just call it, I mean, most of the time, it's gonna be the lining that's gonna be adenocarcinoma.
So if any number of people could have exactly that same, or is it all individually different for every single person?
For the purposes of this test, yes, it's each
For that
individually
test.
different. Though people are gonna have shared, oftentimes they're gonna have shared sort of damage, you know. The same sort of damage is gonna lead to the cancer. It's just, what it does is it specifically looks for genetic fragments for that cancer,
On that individual.
on that individual.
But if you're looking overall for colon cancer, it seems like that would lead more to the causes of colon cancer. If you had a particular cancer that was known to be present.
Well, right. There are, I didn't talk about this, but there are certain conditions that are inherited that predispose a person to have colon cancer earlier in life, or, you know, some people are almost virtually guaranteed to have colon cancer if they have this kind of genetic mutation. So, and those people, if we go in and we see, oh, they've got a lot of polyps, kind of inappropriate, I mean, there's a lot, you know, unusually a lot, we'll test them, and then if that comes up, then we can tell their relatives and say, you need to be tested for this mutation as well. One of them is called Lynch syndrome. It also increases your risk for other kinds of cancers, and then that can give them a leg up on preventing cancer. Well, that's all I've got. I got one more thing. I didn't put a slide about it. Have you seen the news about Vibes? The shaking pill?
Tell us about it.
Okay, so these researchers are thinking about how to help people lose weight. And so what they did is they took a bunch of pigs and they gave them pills. You know how your phone will buzz? Okay, so just imagine just taking that little buzzing part, okay, with a little battery, and it's got a little membrane on the surface of the pill. And when it hits, an acid hits it, it dissolves that and completes the circuit and it starts buzzing. And it buzzes for like an hour. So they gave the buzzing pills to pigs, and the pigs ate less. And what they think is happening is that the sensation of movement in your stomach tells your body that you're full, so you stop eating. And so they want to somehow develop this into a product for people, and I'm thinking to myself, eating batteries every day, that might not be such a good idea. Eventually it's going to cause a problem. But they had something, there was a product previously too, they went out of business, I don't think they're making them anymore, where you take a pill and it would start buzzing in your colon. And the buzzing in your colon was supposed to stimulate you so that you not have constipation. Stimulate you to go to the bathroom. So, I don't know about these buzzing pills. I don't think they'll catch on. But
What is the research being done about the biome?
the microbiome, that's the whole probiotic thing that I was talking about. That they are, beating on that as hard as they can, and they haven't been able to find kind of the magic combination or magic bacteria that are ideal.
I've often heard that the good bacteria in your body and on your skin is your immune system. Is that inaccurate?
I call them your little friends. It's not so, you have more bacteria on the surface of your body and inside your body than you have cells in your body. So there's a lot of them. And they are, you could think of them as a symbiotic organism rather than part of your immune system. Though I suppose if you expanded the idea of your immune system to include, think static defenses. I mean, even if you think about it, washing your hands is something in your brain. Is that part of your immune system? You're thinking about doing something to protect yourself. So, I mean, you could think of them that way.
Well, when you see studies that talk about children that overprotective parents that are keeping little Johnny and Mary perfectly clean all the time, they're never exposed to dirt and all of the rest. They're not as healthy as the kids that got out played in the dirt.
So I did immunology, and it was in a PhD program in immunology, and there's this theory. And the theory is that there's two arms to the immune system. One that's more oriented toward fighting bacteria, and one that's more oriented toward fighting viruses. And the virus one is the one that they, if you're not out there in the sand pit, grubbing around, getting little cuts and getting little exposures to bacteria and having little sore spots on your skin and all that kind of stuff, then perhaps there is a preponderance of focus in your immune system toward viruses, and that so you're unbalanced potentially. That's one of the theories about how you need to be a little bit more exposed to stuff when you're young to have a more even immune system and not have some of these things like maybe even autoimmune diseases or allergies and things like that.
So I was curious, is there a screening procedure for pancreatic cancer?
No, there isn't a good screening. I mean, if a person has a couple of first-degree relatives with pancreatic cancer, we screen those people. But there isn't a good way to know in advance most of the time. There are some blood tests we do, and our threshold, my personal threshold is kind of, if people have any kind of pain or any kind of symptom that might sound like it, we usually we'll get a CT scan and some blood tests to see. There is an interesting little factoid, is that if a person develops diabetes, within the first couple of years, they have an increased risk of developing pancreatic cancer. And you can imagine that there's that connection there with the pancreas is involved in diabetes and producing insulin and things like that. So
Within the first couple of years?
yes. And then after that, it's like, if it hasn't happened by then the risk goes back to normal. So it's like some sort of trigger. Perhaps there's some sort of insult to the body or some sort of immune system event that is causing some damage, and then that damage can lead to cancer developing. It's a little blip, but they've been able to detect that. So
are you saying that cancer is mainly caused by damage and not viral or bacterial?
well, no, not exactly, because I mean you can think of the virus is causing damage. Viruses and bacteria do cause damage. For instance, even if you get, like, say, you get a cut on your arm or something and then it heals, there's increased risk of cancer in the scar.
Let's go.
It's kind of weird.
So when they do breast cancer and they found that there is an increased risk for people, women, who have had a biopsy of benign cysts, that they have an increased risk of cancer in that cyst. Is that because of the damage done by the biopsy versus?
I don't know, you have to ask me.
I don't think so. It's women with dense breasts have a higher rate of breast cancer, but I'm not exactly sure why that is. I'm just a gynecologist, I'm not a general surgeon, but I think our understanding is a little unclear on why that is. They might have more active cells making up at that breast tissue.
Well, that's an issue of it's or breast tissue, but I'm talking about individual cysts.
Yeah, those are part of density on
Oh,
mammograms.
that's
Cysts
just,
look very dense.
okay.
So there's something called fibrocystic breast change, which causes breast tissue to be dense, and cysts are part of that. So I think there's probably some unanswered, and not all the answers are there with some of that cyst and density and cancer risk. But I believe that it is not thought that the biopsy itself is contributing to cancer down the road. So I don't think women should be afraid to have a breast biopsy if needed, and worry that that biopsy is gonna cause them to have cancer later. But there are some unknowns about cysts and density and cancer risk and why that would be increased.
There's a lot of things that it's like, it's difficult sometimes to figure out correlation versus causation, you know? There was obviously a reason why they wanted to do the biopsy. Biopsies can also sometimes miss it. They just hit the wrong spot. So, any other questions?
So if you have chronic inflammation of something, then that is more likely to be, that you could have a cancer because of that. Because of the inflammation.
Yes, so
inflammation
people that
around
have
it.
ulcerative colitis or Crohn's disease, they have an increased risk of developing colon cancer. So after a certain period of time, we will start to do colonoscopies on an annual basis.
A lot of us, that when we get to a certain age, say, either they think we're gonna die pretty soon, or they say, you don't need to have a colonoscopy anymore.
That is because we also know that if you're not, if say for instance you go in, you're 60 years old, you get a colonoscopy, it's completely pristine, everything looks great. And they go back in 10 years later when you're 70 years old, it's completely pristine, you're great. You're just not the kind of person that's gonna, apparently either your immune system or your, you know, whatever is working, you haven't, maybe you've just lived a godly life. And you haven't done anything that would cause any damage, enough damage to your colon that it's gonna be the problem, you know, as you age. And so we just say, why are we going to bother you when you're 80 years old? You know, usually it's if your colonoscopy is, your next colonoscopy is gonna put you in your mid-80s, we stop if the past couple of ones have been normal. Now, if they find something there, that all bets are off, you know, we'll still do it if your person is healthy and willing. Okay, thank you, I appreciate it.
Thank you.